Hello, everyone, and thank you for joining us. My name is Ashley McDermott. I am with the AIUM, and I'll be your host. As part of our continuing education for healthcare professionals, I am pleased to host this webinar, Thumbs Up, Musculoskeletal Ultrasound of the Thumb, presented by Dr. Daniel Kowal. This is a non-CME educational activity in collaboration with Samsung. This webinar will review ultrasound imaging technique of the thumb and explain normal anatomy. Again, this is a non-CME educational activity in collaboration with Samsung. If you have questions for the presenter during this webinar, you may type them into the Q&A. You will be able to submit questions throughout this webinar, but the presenter will not begin addressing them until he has completed his presentation. This webinar is being recorded, and you will receive a follow-up email within 24 to 48 hours with a link to view the recording. And now I am pleased to present Dr. Kowal.
Thank you, Ashley. Let me share my screen. All right, I'm excited to talk about the thumb musculoskeletal ultrasound. So I'll start with an outline. I'm going to begin with imaging technique and normal anatomy, and I'll kind of build on the anatomy as we talk about each section rather than throwing it all at you at once. And then I'll begin with the dorsal tendons. We'll talk about de Quervain's tenosynovitis, intersection syndrome, inflammatory tenosynovitis. Then we'll flip over to the ventral tendon, mainly focusing on trigger thumb. And we'll talk about ulnar collateral ligament injury of the thumb with gamekeeper's thumb. Rather than talking about all of the arthritides that can occur at the thumb, I'm going to just briefly focusing on osteoarthritis in the interest of time, since that's so common in the thumb. Then I'll move on to thumb masses and how to differentiate between the different types. And then I'll finish up with the post-operative thumb, how to evaluate tendon repair and opponentsplasty. So for imaging technique, it's key to use a high-resolution linear transducer. So all the images that you'll see in this presentation, we obtained using a Samsung RS-85 Prestige ultrasound using one of these three transducers, a 14, 18, or 22 megahertz. And dynamic imaging is extremely helpful, as well as cine clips. And when you're obtaining cine clips, I highly recommend you include bony landmarks and also label the image orientation as far as like radial or ulnar side, because it can be very confusing when you're reviewing the images later on to determine what exactly was I scanning. Comparing with the contralateral asymptomatic thumb is also very useful, particularly for those equivocal cases. And in addition to color Doppler, using power Doppler and microvascular flow can be useful to detect hyperemia that can indicate irritation and inflammation. And finally, just like everything in MSK ultrasound, using a boatload of gel is very helpful because there are so many grooves and nooks and crannies that can really improve your acoustic window. All right, so let me start with some anatomy here. Just a second. So here's the thumb X-ray. And the radius and ulna are proximal here. Technically, the radius is anatomic lateral and ulnar is medial, but that becomes very confusing. So I recommend instead describing everything as radial sided or ulnar sided instead of medial or lateral. So this would be the radial side of the thumb. This would be the ulnar side. Distal to the ulna and radius, we have the carpal bones. The only carpal bone we really need to worry about for this presentation is this one, the trapezium, because that will articulate with the first metacarpal here. And then we have the proximal phalanx of the thumb and the distal phalanx. And the joints there, we have the first carpal metacarpal joint between these two. And then we have the metacarpal phalangeal joint and the interphalangeal joint. So you can see that the thumb is not just another finger. It's got its own unique anatomy. All right, so starting with those dorsal tendons, let's look at an axial MRI. So this is an axial view of the wrist here. We have the radius and the ulna. And for the extensor compartments on the dorsal side of the wrist there's actually 6 compartments. But don't worry, we're not going to talk about all those. For the thumb, we really only need to worry about the first 3 compartments. And we're just going to start with compartment 1 and compartment 3. So compartment 1 has two tendons. It has the extensor pollicis brevis and the abductor pollicis longus. And one key to remember here is that the abductor pollicis longus is abbreviated APL. So I kind of think of this as an apple hanging off of a tree branch. That's how I remember that this is the most ventral tendon. I don't know if that will help you or not. And then in compartment 3, we just have one tendon, the extensor pollicis longus. And you'll see that's right next to Lister's tubercle, which is this little bony outcropping. That's a great ultrasound landmark to find this tendon. And you can also notice that each of these tendons has the word pollicis in it. So that's a clue that we're dealing with thumb tendons. So let's look at a diagram of that. And we'll start with the extensor pollicis longus. So that's the most distal insertion of these tendons. It will insert on the base of the distal phalanx. And for imaging that, I'd like to thank my resident Dr. Jordan Fielding for volunteering his thumb for these images. If you'd like to hire him as a hand or a thumb model, I can refer you to his agent. But this is using a hockey stick 22 megahertz transducer, and we're oriented over that interphalangeal joint, and this is the image that you'll see. So the extensor pollicis longus here is inserting onto that distal phalanx. This is the interphalangeal joint. There's the proximal phalanx. Now, if we're looking at the extensor pollicis brevis, brevis is shorter than longus, so that will insert a little more proximally. That inserts at the base of the proximal phalanx here. And so we've moved the transducer a bit more proximal, still in long axis here. And you can see the EPB is inserting there at the base of the proximal phalanx. And this is now the metacarpal phalangeal joint. And the third tendon, the abductor pollicis longus, that will have the most proximal insertion. That'll be into the base of that first metacarpal. So here we have the thick APL tendon inserting there at the base of the first metacarpal. And that's the carpal metacarpal joint. Two things that are unique about this tendon: when it's in short axis, it can sometimes have a lotus root configuration. I don't know how many lotus roots you've cut through, but that means it has you can see multiple slips that can kind of mimic tears that I'll show you in a later case. And also this tendon tends to have numerous tendon slips, accessory tendon slips that can be confusing. And one way to remember that this tendon has so many is, again, think about all the varieties of apples there are. Granny Smith, Red Delicious. APL has many variants. You can tell I live in New England and I like apples around this time of year. And then finally, we have this kind of band-like extensor retinaculum that extends over the tendons. Here we're imaging at the level of compartment 1, where it's crossing over the APL and the EPB tendons. And you can see normally it will be hypoechoic and thin relative to these echogenic tendons there. And you can see where we are imaging here, kind of right at the radial styloid region. So keep this appearance in mind for this next case. So this was a patient that presented with radial-sided wrist pain. So here's the radius again, and it's subtle, but there's some mild soft tissue swelling overlying the radial styloid. The radial styloid is this little bony ridge here at the edge of the radius. So now if we put the transducer right over this area and turn in short axis, we'll get this image. And we can see that there's the EPB and the APL. Again, this is compartment 1, and this is the radius here. Over that, you can see this very thick hypoechoic extensor retinaculum. And when we turn on long axis there, we can also see the thickened extensor retinaculum overlying the tendons there. And this is a typical example for de Quervain's tenosynovitis. So this is a stenosing tenosynovitis of this first extensor compartment. And it's actually the second most common hand entrapment tendinopathy after trigger finger, which occurs on the ventral side. We see this most commonly in middle-aged females. It can be idiopathic or due to repetitive motion. And it also has an increased incidence during pregnancy. And the patients will present with pain with thumb and wrist movement, and often tenderness and swelling over that radial styloid. Classically, there'll be a positive Finkelstein maneuver, and the way that is achieved is if the patient's thumb is grasped and then the hand is ulnar deviated, there'll be pain over that distal radius. And so what we look for in ultrasound is increased fluid in that tendon sheath. And when we have fluid expansion in the tendon sheath, that tells us there's some form of tenosynovitis. Also, the tendons may become hypoechoic and thicken due to edema. That indicates tendinosis. And almost invariably, we have this thickening of the extensor retinaculum. And rather than worry about a specific measurement for this thickness, because it can be variable, it's often helpful to compare with the patient's contralateral asymptomatic side. So here on the symptomatic side, the thickness was 1.6 millimeters. On the contralateral side, though, it was normal thin hypoechoic, only about 0.2 millimeters. So quite a drastic change. And like most things with MSK ultrasound, it's better visualized in real-time imaging. So here's a short axis series starting at the upper wrist, moving distally. So here we have compartment 1 at the muscles, where the muscular tendinous junction will normally cross over towards the radial side over these compartment 2 tendons, and here's the radius. So here we are, the compartment 1 is normally crossing over compartment 2. This is normal. The patient had no tenderness here. There's no fluid. Now we're continuing to follow compartment 1 here distally, and now we're getting close to that radial styloid where the patient's symptoms are, and you can see there's that very thickened hypoechoic extensor retinaculum. There's the APL and the EPB tendons. And as we go a bit more distally, you can see this is that lotus root configuration that I had mentioned, where it looks like there are multiple little slips and these alternating hypoechoic areas that you may confuse with a tear, but that's just kind of a normal variant. And we continue to follow that APL to where it inserts onto the base of the first metacarpal right there, and then the EPB will continue on to the proximal phalanx of the thumb. So real-time imaging, always helpful. All right, let's look at another example. This is a patient with left radial-sided pain. This was a female in her 20s that presented with this pain during the late stages of her pregnancy. You can see some subtle soft tissue swelling there again. And when we zoom in, there's also another finding that kind of suggests that there's a repetitive friction phenomenon going on. It's subtle, but there's some mild cortical lucency erosion there and some slight sclerosis, so some minimal bony remodeling. So again, if we put the transducer right over this radial styloid and turn transverse, it looks similar to that last case. We have a very thick extensor retinaculum over the compartment 1 tendons, and there's the radius. So typical for de Quervains. Now, with de Quervains too, it's very helpful to evaluate this dynamically. So here we have the patient abducting the thumb. This is the APL. Notice how it's kind of getting bunched up beneath that thickened extensor retinaculum. So that tells us that there's some tendinosis because it's a little hypoechoic and thick, and also some impaired tendon movement. So, and we look at that in static on long axis, you can see thick heterogeneous extensor retinaculum. When we add microvascular flow imaging, MV flow here, which is a great way to evaluate slow flow in small caliber vessels, you can see it's avidly hyperemic, telling us there's some ongoing irritation there. So one of the things we'll look for under ultrasound is there impaired tendon movement? And not only is there tendinosis, but could there be a tear? And how do you differentiate that? Well, tendinosis will just be hypoechoic edematous enlargement, like dark, whereas a tear will be completely black, an anechoic cleft of fluid. So this patient did not have a tear, just tendinosis. And again, don't confuse that normal APL slips with the tear, the lotus root sign. And when severe, we'll see this kind of retinacular hyperemia and also some peritendinous hyperemia. Here, with the same patient here, we're turning on short axis. You can see some of that peritendinous hyperemia. Notice how the APL is hypoechoic and tendinosis there. You notice anything else here, which is a variant that's important to identify? Well, there's some fluid here asymmetrically around this EPB tendon. We don't see that extending around the APL. So that tells us that there's likely a vertical septum here. So that's a useful variant to identify because it can help to properly guide steroid injection. Because if just one side is injected, then you might not get even distribution of the steroid because it will be loculated around one tendon slip. These patients also might have an increased incidence of asymmetric tendon involvement. And if steroid treatment does not help along with other conservative measures, then these patients may need to go on to surgical decompression, which is what happened with this patient, and that confirmed the presence of a septum. And that the conservative therapy is also more likely to fail when a septum is present. So that's one of the roles of ultrasound, is identify, is there a septum or not? All right, so let's look at the wrist extensor compartment number 2 here. So that also has 2 tendons within it. It has the extensor carpi radialis brevis and the extensor carpi radialis longus. And you may be saying, Dr. Kowal, this is a lot of tendons to remember. One clue here that can help you remember is notice that when you start with the EPL, compartment 3 here, it goes longest, brevis, longest, brevis, longest. So it alternates. And especially when you're starting out, don't necessarily worry about the names of the tendons. You could just remember, okay, compartment 3, compartment 2, compartment 1, and it can be labeled as that way on the ultrasound. So for this next case, we're going to look at a part where compartment 1 will normally cross over compartment 2, as I mentioned a moment ago. But does this look similar to that first case? So this patient came in with a distal forearm lump and had pain after shoveling with some decreased range of motion. So here we're over the radius and the distal forearm upper wrist. So this is compartment 2 here. There's the ECRB and the ECRL. And then this is the compartment 1 tendon. Here's the muscle of compartment 1. So this is the musculotendinous junction. And that, again, will normally cross over as compartment 1 heads radially towards the thumb. But what's different about this? Well, you can see the tendon is very thick and heterogeneous compared to the normal compartment 1 tendon. And there's also some fluid deep to that tendon surrounding these compartment 2 tendons. And the muscle here looks a little edematous and hypoechoic. When we turn on long axis in this area, you can kind of see that hypoechoic heterogeneity at the myotendinous junction. When we add MV flow, it's very hyperemic. And then let's look at this in real time. So again, there's the ulnar side, radial side. Here's the radius, compartment 2, and then compartment 1 is crossing over. So as we move proximal to distal, look how thick that compartment 1 tendon is. We're seeing fluid around compartment 2, and that indicates that there's this proximal tenosynovitis, along with this edema here at the myotendinous junction. So this is an example of proximal intersection syndrome. So this is an overuse tenosynovitis that occurs usually due to repetitive friction. So as I mentioned, that musculotendinous junction of compartment 1 will normally cross over compartment 2, and proximal to Lister's tubercle, which is kind of at the distal radius. So that's what we're looking at here. This is compartment 1, and you can see how it's normally crossing over compartment 2. But when friction occurs here, then you can get a localized tenosynovitis. And patients will have pain with sonal palpation in this region, also hypoechoic swelling and fluid. And ultrasound is great at diagnosing this. Now notice that there's a second spot more distally where we also have a tendon crossing over the compartment 2 tendons. And so can you get distal intersection syndrome? Yes. So this is a more focused diagram showing the EPL compartment 3 also crosses over compartment 2 more distally. So this is not as common as proximal intersection syndrome, but it can kind of be associated with thumb pain. And the one way to differentiate this is this will be distal to Lister's tubercle, which is this area here. Also, you may wonder, can this overlap with symptoms of de Quervain's? Well, de Quervain's usually occurs a bit more radial over here, because here's the extensor retinaculum covering compartment 1. So this will be a little more ulnar in the wrist. So how will this look on ultrasound? Oh, and this is where that proximal intersection will occur. So if we put the transducer right here, this is what we get with this patient. So does this look normal? Well, we have the ECRB tendon here, which is a compartment 2 tendon. It looks a little thick and there's some fluid around it. The ECRL tendon looks even worse. The tendon's a bit hypoechoic, but we have quite a bit of heterogeneous hypoechoic fluid surrounding it. And when we turn long axis on both of these tendons, we get a similar appearance. There's the tendon with some surrounding fluid. The ECRL is more involved. The tendon, we see the compact fibrillar structure of the tendon, which is expected. But then look at all this hypoechoic expansile fluid in the tendon sheath, indicating tenosynovitis. Let's add some color Doppler to this ECRL, and you can see that hypoechoic fluid is somewhat vascular, indicating that there's some synovitis. When we add MV flow, it brings out even more vascularity. And if we turn short axis on that, it's quite dramatic around that ECRL tendon. So quite a bit of hyperemia corresponding to the patient's pain. And if we look at this in real time, so here's the radius, here's compartment 2, and we're going to move proximal to distal and watch as the third compartment tendon crosses over. So there it is right there, crossing over, and then you've got this complex heterogeneous fluid around the ECRL tendon just distal to that area. So just to show you again, compartment 2 moving distally, then the compartment 3, the EPL is crossing over to the thumb, and then there's fluid around the ECRB and more pronounced fluid around that ECRL. So typical case of distal intersection syndrome, less common than the proximal type. All right, so let's move back up to the proximal wrist. Here we are again at kind of the site of the proximal intersection. This is a different patient showing the second extensor compartment, and these are the first extensor compartment tendons, and there's a tremendous amount of this hypoechoic fluid around it. So is this another case of proximal intersection syndrome? Well, I've already showed you that once, so I probably won't show it again. But if we move distally, we see similar complex fluid around the distal aspect of compartment 1. So intersection syndrome is usually more of a focal abnormality, whereas this, what we're looking at, is more diffuse. And if we turn sagittal, we can really appreciate around this compartment 1 tendon, there's quite a bit of this heterogeneous hypoechoic fluid indicating that there's some complex tenosynovitis. And if we evaluate that with dynamic motion to extend that tendon, you can see that all this complex debris is swirling around, indicating that it's not solid. When we add color, there's tremendous flow. These are short axis views, so we've confirmed that there's some active hyperemia and inflammation. And again, with MV flow, it really brings out that vascularity even more pronounced. And looking at this patient's history, they had a history of gout. So this was an example of inflammatory tenosynovitis secondary to gout. So as I mentioned, tenosynovitis indicates distension of the synovial sheath surrounding the tendon. And it can be degenerative, traumatic, or due to repetitive injury like we've been observing, but it can also be inflammatory due to crystal deposition like in gout, or infection. And in my practice, the causes of infection we see are most commonly due to IV drug users. And if the fluid distending the tendon sheath is anechoic, that suggests that it's just simple, like a simple tenosynovitis. But if the fluid is hypoechoic or hyperechoic, and if it's compressible with swirling echoes and lack of flow, you can kind of assume that's just complex fluid. But if it's non-compressible and there is flow, that usually indicates synovial hypertrophy. And this patient had a combination of both, which is often the case. Now, if we return to this patient, we're scanning at the level of the distal wrist. Again, we're at the first compartment. You can see all that complex fluid and synovial thickening. But what else do you notice here looking at the tendons? So there's the EPB and there's the APL, but why are there two APLs? Is there a longitudinal split tear here? No, this is a common pitfall. Because again, as I mentioned earlier, the APL can very commonly have an accessory tendon. Some of the literature states at least 33%, if not 100% of patients will have some type of accessory APL tendon. And it's been well studied, so that terminal tendon will split and then insert onto the APB muscle, the abductor pollicis brevis. Also, it could insert onto the base of the first metacarpal, the trapezium, or even the opponens pollicis muscle, which is one of the thenar muscles. So if we go back to this patient and evaluate it in real time, there's the EPB, there's the APL. And as we go distally here, you can see there's the EPB and the APL, and this is that lotus root appearance. And we can start to see that accessory tendon branching off. And watch where this goes. As we keep going, we can see it inserting here into this thenar muscle. So that's the APB. So this was the most common variant. And the way you can differentiate this from a split tear is a split tear, with this tendon, it should rejoin the original tendon if it was truly a split tear, but instead it branches off. And often these variants become more pronounced when there is tenosynovitis because the tendon sheath is distended and it makes all the tendons much more conspicuous. So it's a pitfall, and it's one of those challenges when you're first learning MSK ultrasound to be aware of. All right, so let's flip over the thumb now and look at the ventral tendon. And for the ventral side, there's really just one tendon, so that makes it a little easier. The flexor pollicis longus. And that will insert onto the ventral base of the distal phalanx. So here we're scanning the ventral side, and this is the body of the tendon. So if we move the transducer a little more distally over the distal phalanx, we'll get this image where you can actually see the tendon coming down to insert on the distal phalanx. And there's often a little ossicle here at the interphalangeal joint. That's normal. It's kind of near the volar plate here. So this area here is if we're imaging right here. And the other thing we have on this side are these annular pulleys. So those will actually hold the flexor tendon close to the bone to prevent bowstringing. They're kind of like little seat belts. And there's three major ones. There's this A1 pulley at the MCP joint. There's an oblique pulley at the proximal phalanx that will extend from ulnar to radial. And then there's an A2 pulley just proximal to the IP joint here. But for our purposes, we're really just going to focus on that A1 pulley because that's the one that's easiest to see and most commonly abnormal. And it will appear on ultrasound as a little thin hypoechoic structure overlying the flexor pollicis longus tendon. And this is normally less than 0.5 millimeter in thickness. You can see this looks very similar to the extensor retinaculum on the other side, right, where we would have de Quervains. So look at this, keep this image in mind, and we'll look at another patient who actually had some pain on this side right here. And this patient had a trampoline injury, and was unable to straighten their thumb. So you can see that the A1 pulley is very thick and hypoechoic over this FPL tendon. If we turn on long axis, we can see there it is, very thick. It measures about 1 millimeter, which is at least twice its normal thickness. And notice the underlying flexor pollicis longus tendon is a bit bunched up there and abnormal in configuration. We definitely want to evaluate this under dynamic evaluation. So here we're flexing the patient's thumb. You can see that thick A1 pulley. And notice how the FPL tendon is kind of bunching up. There's some abnormal motion there, a bit of restricted movement over the underlying bone there. So this is a typical example of a trigger thumb. So with trigger thumb, there's impaired flexor tendon movement due to a thickened pulley leading to this tendon constriction. And it's a type of tenosynovitis similar to de Quervain's, but where it's involving the flexor tendon as opposed to the extensors. And it's commonly described in the ring and middle fingers, but the thumb is also often involved. We see this more commonly in the patients in their 5th to 6th decades, but this was actually a younger patient that had a post-traumatic cause. And also a good notice to not use trampolines. This is often idiopathic, but can also occur with repetitive microinjury. Here's another example. Again, notice that very thick A1 pulley over the flexor pollicis longus tendon. With MV flow, there's some increased vascularity there. Scanning the patient's asymptomatic contralateral side confirms that this is definitely abnormally thickened. Look at how thin and hypoechoic this is, sub 5 millimeter in thickness. And when we evaluate this in sagittal, we can see the thickened A1 pulley there over the level of the MCP joint. And what do you notice about the flexor pollicis longus tendon? Well, we have some buckling there, some abnormal contour, but we also have this hypoechoic irregular area. And that's known as the dark tendon sign. And what this is an anisotropic hypoechogenicity of the flexor tendon at that pulley. And it's being caused by this tendon constriction because of the thickened pulley. So what that anisotropy, what that means is normally when the beam comes down and hits the tendon at a 90-degree angle, the tendon will be bright and echogenic due to the orientation of these compact fibrillar fibers. But if it's hitting it at an angle other than 90 degrees, like here where it's bunched up and constricted, we'll get this irregular geographic region of hypoechogenicity yielding that dark tendon. And that's nicely appreciated here on real-time scanning. There's that thick A1 pulley here, and then you can see the abnormal contour of the FPL tendon. And notice this dark area that's kind of intransitely appearing and shifting. So that's a very useful feature when confirming the diagnosis of tendon constriction in this setting. All right, so let's move on and talk about gamekeeper's thumb. So for gamekeepers, we're mainly talking about the ulnar collateral ligament of the thumb. And returning to our thumb x-ray here, it's the ulnar collateral ligament of the MCP joint specifically. So that will occur right there. This is the ligament that we're worried about. The best way to image this is to place the hand around a rolled up towel with the transducer in a coronal plane relative to that MCP joint. And you can see it's hard to get in there otherwise. So this kind of opens the area up, and that will yield this image. So you'll see the ulnar collateral ligament here extending from this broad concavity here at the metacarpal, and then it extends down to the attached on the proximal phalanx. So when you're imaging this, you want to try to see this concavity, and that tells you you're in the correct plane. There's also a very thin overlying adductor pollicis aponeurosis that can be hard to see when it's normal, but that will overlie the ulnar collateral ligament. And so when you're evaluating this ligament, it's essential to do some dynamic maneuvers. And one of them is to apply some valgus stress at the MCP joint gently. You don't want to force the thumb too much, just enough to slightly widen this joint. And you'll see there's the ulnar collateral ligament, and this kind of confirms that it's intact. So if there was a tear, some of the physiologic fluid in this joint would extend into the ulnar collateral ligament. And that will help you detect it. Also, the ulnar collateral ligament is normally a little hypoechoic relative to the overlying echogenic fat, but this might help to bring out that compact fibrillar structure and uniform thickness. You can also compare the gap of the joint with stress compared to the contralateral asymptomatic side. So this was a patient that was not asymptomatic. What do you think about this ulnar collateral ligament? Here's the metacarpal proximal phalanx. You can see the ligament's quite thick and heterogeneously hypoechoic. And if you're not sure, compare to that contralateral asymptomatic side, and you can see how nice and uniform it is. And we've got a nice fibrillar pattern. And let's do that valgus stress that I had just mentioned on the abnormal side. Notice that there's some fluid that's kind of tracking into this area. You can really see how heterogeneous the tendon looks. Even the overlying adductor aponeurosis looks a little thick and hypoechoic. And so this is a patient with a partial thickness sprain of that tendon. I'm sorry, of that ligament. And let's see why she has the injury. So this was an x-ray from 3 months prior. Do you notice any abnormality? Yes, the metacarpal phalangeal joint there is dislocated. And so you can see the ulnar collateral ligament is here. So you can imagine how it was partially torn and sprained quite severely. So this had been since relocated, and the ligament somewhat healed, but not entirely. And this is known as gamekeeper's or a skier's thumb. So this indicates some form of disruption of the ulnar collateral ligament of the first metacarpal phalangeal joint. It's typically due to a fall on an outstretched hand with the thumb abducted, and that was the history with this patient. And we'll see this abnormal ligament that will look hypoechoic and thickened. And again, comparing to the other hand and doing dynamic maneuvers is essential. It can be difficult to differentiate between a partial tear and a non-displaced full thickness tear, but it's more important to identify a displaced full thickness tear, and that's called a Stener lesion. So let me just show you a diagram of that. So this is the normal ulnar collateral ligament of the MCP joint. And here's the adductor aponeurosis here of the adductor pollicis muscle. And you can kind of see how it attaches to the proximal phalanx of the thumb here, and it covers this ulnar collateral ligament. So if you have a tear of the ligament here, and it flips over proximal to this adductor pollicis aponeurosis, that's when you have a Stener lesion. And that will appear as a hypoechoic round mass-like focus, often with shadowing. Important to identify because that will not heal without surgery. This diagram is also nice because it kind of explains how the adductor aponeurosis can move separately from the overlying ulnar collateral ligament if you flex the distal thumb. And let me show you an example of that. So this was a different patient who presented with a non-displaced ulnar collateral ligament tear. You can see there's the ulnar collateral ligament, heterogeneous hypoechoic, there's the anechoic cleft. And what else do you notice here with this patient? Well, the overlying adductor aponeurosis, which was almost imperceptible on that normal patient, is very thick, hypoechoic, and heterogeneous. So that tells us that there's also an aponeurotic injury. Now, is this a full thickness tear? How can we evaluate that? So if we, instead of applying stress to the MCP joint, if we instead just flex that interphalangeal joint of the thumb by grabbing the distal phalanx and flexing it, that can isolate this adductor neurosis movement. And you can see how it's moving, and the fact that we have contiguous movement tells us there's no full thickness tear. It can also help kind of separate where is the ulnar collateral ligament versus where is this aponeurosis. So that's the second essential dynamic maneuver you should do when evaluating the ulnar collateral ligament. And again, if we compare to the patient's normal asymptomatic side, you can see that adductor aponeurosis is almost imperceptible there, very thin and normal looking. All right, so let me change up a bit and we'll talk briefly about osteoarthritis. So here's our hand x-ray again, and we're really just gonna focus on this joint here, the first carpal metacarpal joint, where osteoarthritis is most common in the thumb. So for this next case, we're putting a transducer right here and we're imaging in the coronal plane. So there's the trapezium, and then here's that first metacarpal. And notice how there's some osteophyte formation there, this kind of bony ridge. And we also have some hypoechoic synovial hypertrophy overlying it. If we move a bit off axis there, you can see that this cortical irregularity and osteophyte formation is quite pronounced on both sides of the joint. Ultrasound is extremely sensitive for detecting osteophytes and erosions. And if we look at this in real time, there's that trapezium osteophyte. And then here a bit more distally, there's the first metacarpal. And then this is all that hypoechoic synovial hypertrophy there surrounding it. So typical first CMC osteoarthritis. So this occurs due to wear and tear of the joint leading to cartilage loss and then this kind of bony spurring or osteophyte formation. And this location is very common in the thumb. Usually when I'm imaging the thumb, I'll always scan down here because it's an easy way to just determine if osteoarthritis is contributing to the patient's thumb pain. And there's often associated synovial hypertrophy, but it's usually mild and not that hyperemic. If you ever do see really pronounced hyperemic synovial hypertrophy, then you want to start thinking about inflammatory arthritis, specifically rheumatoid arthritis. And again, synovial hypertrophy won't typically be very compressible, unlike joint fluid. And joint fluid can also occur with osteoarthritis. So here's a different patient. At the same point, we're at that first carpal metacarpal joint. Notice the trapezium osteophyte, first metacarpal osteophyte. And do you notice anything else highlighted by an asterisk? We have this anechoic joint fluid here with some overlying synovial thickening. So this was arthritis with a joint effusion. And if we look at that on cine, you can see there's that joint effusion there with the overlying synovial thickening right there. And notice those osteophytic joint margins. Now, this patient had an x-ray 3 months prior, and it should look familiar because this is the patient with the metacarpal phalangeal joint dislocation. Do you see any other injury that she sustained with her fall? Yeah, there's a fracture there, and it's an intra-articular fracture at the base of that metacarpal. So it's extending down to the first metacarpal joint, and then it evolved into this. So this patient developed post-traumatic osteoarthritis. So this is fairly common. We typically see this in patients younger than those who develop primary osteoarthritis from wear and tear. And this can be due to bone and cartilage damage, but it can also be due to like post-inflammatory changes or chronic joint instability. So it's something to consider when you see monoarticular osteoarthritis, particularly in a young patient or in a distribution that's not typical for osteoarthritis. And of course, if there's a history of trauma. All right, so let's move on to thumb masses. So I'll start by reviewing some of the thenar eminence anatomy. So the thenar eminence is that fleshy part at the base of the thumb pad. And so this image here is a short axis image of that region. Here's the radial side. This is the ulnar side. And you can see there's the first metacarpal of the thumb. And then this tendon is that flexor pollicis longus tendon that I showed you more distally, inserting on the distal phalanx. And then all these surrounding muscles make up the thenar eminence. So for most purposes, that's really all you need to know for the anatomy in this region, especially if you're just starting out with MSK ultrasound. But know that you can actually separate all the muscles out in this region. So I'll go through those. There's 4 muscles. So the most superficial and radial is the abductor pollicis brevis. So that's this muscle over here. So that will be superficial and on the radial side. There's also the flexor pollicis brevis. So that will be superficial, and it also has a deep head. And it's separated by this flexor pollicis longus tendon. So that's a great landmark to find the muscles above and below it. The third muscle is this opponens pollicis. And that's able, you can identify that because that's actually deep to the APB and it's radial to the flexor pollicis brevis. And notice that it's also at the same level of the flexor pollicis longus tendon. So that's a good way to identify it. One thing I find extremely helpful is this also inserts into the length of the first metacarpal. So you'll see it intimately associated with the first metacarpal, which makes it easier to identify because these other muscles, their tendons all kind of converge in the region of the proximal phalanx. And then finally, the fourth is this deeper adductor pollicis muscle. And you'll see that's deep to the flexor pollicis brevis. All right, so let's apply some of that anatomy to a case. So this patient presented with thenar eminent swelling. There was a concern for mass or edema. And we can see a short axis view here. We've got this ovoid, heterogeneously echogenic striated mass-like focus. And where is it? So there's the first metacarpal. So it's often helpful to identify the bony landmark first. And then remember the APB is the most superficial and radial. So this is the radial side. So that's radial. So that means this must be the flexor pollicis brevis. And then which muscle attaches to the first metacarpal? Opponens pollicis. And that's at the same level as the flexor pollicis longus tendon. So we can kind of see this is an intramuscular mass right in the center of the thenar eminence. When we turn on long axis, it kind of confirms that it's totally intramuscular here. It's bilobed. On color Doppler, there's little to no vascular flow. So this patient then went on to have an MRI. And this is a proton density axial view. So it's a short axis view, you can think of it. And there's the mass. Notice that it has the same intensity as the subcutaneous fat, which is a clue. And we can identify those same muscles of the thenar eminence here. So there's the first metacarpal. So this is the APB because it's superficial and on the radial side. There's the FPB, and then again, the muscle attaching to the first metacarpal here is the opponens pollicis. So nice comparison of the anatomy. Now, if we look at the T2 fat suppressed axial, so normally fat will be bright on T2. You can see the subcutaneous fat is all dark, and so is the fat in this lesion, or the signal in this lesion. So that kind of tells us that this is a fat-containing mass. And this is a thenar intramuscular lipoma. So this is the most common benign subcutaneous soft tissue tumor throughout the body. It usually appears ovoid, partially compressible, iso to hyperechoic relative to fat, often has some striations like this. It may have a thin pseudocapsule. And it's usually doesn't have much vascularity. Differential on ultrasound would include some fatty infiltration because that can look similar, but often you'll have associated atrophy. And then edema can also be echogenic. And MRI is useful for problem solving, particularly if there's suspicion for like a low-grade liposarcoma. All right, let's go on to a common wrist mass here. So this is a patient presenting with a palpable mass at the radial aspect of their first metacarpal. And what do you think about the contents of this lesion? Here it looks a little bilobed on long axis, but it's purely anechoic. There's some posterior acoustic enhancement. So we want to know, is there any flow in this lesion? So we add color. There's no internal vascularity, but we do have an adjacent vessel that might be useful for the surgeon to know about. And this is a simple ganglion cyst. So ganglion cysts are the most common hand and wrist mass. They're viscous or mucin-filled collections. They don't typically have a synovial lining, and they are usually well-defined. They can be multilocular or unilocular, and they'll be purely cystic, anechoic with acoustic enhancement. They should be avascular, although you may see some vascularity within septations, and it's very helpful for the surgeon if you describe any adjacent vessels, so they don't encounter any surprises when they go in to resect it. And they should be non-compressible, unlike tenosynovitis, which will be compressible, and other simple fluid collections. Now, here's a variant of a ganglion cyst. So this patient presented with a painful nodule at their ventral thumb, and they had symptoms of trigger thumb, stenosing tenosynovitis. So here we are imaging the A1 of the thumb and short axis. You can see the A1 pulley there is thickened. Remember, it shouldn't measure over 0.5 millimeter. So that's consistent with the history. But we also notice that there's this cystic area that we can kind of bring out when we angle a little bit better. And when we turn on long axis, there it is here, this 8 mm heterogeneously hypocoexistic focus directly over the pulley. And this is a peri-pulley ganglion cyst. So these can kind of complicate pulley abnormalities. I see these most commonly in patients that are coming in with a clinical suspicion of trigger finger or trigger thumb. Helpful for the surgeon to know, because then they can prepare to resect that intraoperatively. This one actually ruptured when they were doing the surgical release of the A1 pulley. But that's a location where ganglion cysts can occur. And another variant of a ganglion cyst occurring in a unique location. So here we're at the patient's thumb tip. This is the dorsal thumb. So we've got the proximal phalanx, interphalangeal joint. There's the extensor pollicis longus tendon inserting onto the distal phalanx. And we can even see the nail bed here. And notice that there's this anechoic cystic structure there over the IP approaching the nail bed. It's a little multilocular. Here you can see we really went to town adding extra gel because that's very helpful to evaluate this area. There's the nail. And as we continue to image that area, you can see it's a bit multilocular, and it kind of insinuates partially under the nail bed, which is key to this diagnosis. So here it is on real-time imaging. There's the cyst partially overlying the IP joint. There's the nail. And notice how the cyst is slightly multilocular, insinuating right here deep to that nail bed. So that is very typical for a digital mucus cyst. So these are ganglion or degenerative cysts that occur in a very specific location, usually arising from the interphalangeal joint of the thumb, or if it's the finger, it'll be the most distal interphalangeal joint, and then kind of extending towards the nail bed, and it may insinuate deep to it. So a digital mucus cyst. Let's look at a more solid mass. So this patient presented with a mass at their ventral thumb. And you can see here, there's the mass. We're seeing the edge of it, and it's overlying the flexor pollicis longus tendon. And do you recall which muscles the flexor pollicis longus divides of the thenar eminence? The flexor pollicis brevis, the superficial and the deep heads. So now if we image a bit more distally here, you can see now we're catching the full mass on long axis. There it is over the flexor pollicis longus tendon. It's hypoechoic, solid looking. When we turn transverse, it seems like it's almost partially encasing the tendon, very large. And now what do you want to do next whenever you see a mass that's so close to a tendon? Well, let's flex that thumb and we can evaluate this in real time. So you can see the nice fibrillar structure of the FPL. It's moving normally, and this is not moving with it, suggesting that it's not arising from the tendon, but from the tendon sheath. When we add color, there's some increased vascular flow. And that's brought out even further with MV flow, showing that slow vascularity. And this is typical and was pathologically proven to represent a giant cell tumor of the tendon sheath, also known as localized nodular tenosynovitis. So it's the second most common mass of the hand and wrist after a ganglion cyst. And we see this most commonly on the first three fingers. So that includes the thumb. That's the first finger. And it's usually homogeneously hypoechoic with these well-defined margins, closely associated with the tendon, but will not move with the tendon because it arises from the sheath. And it usually shows some degree of vascular flow. Let me show you another example. So this one here, we're looking at the thumb. This one in short axis here, there's the mass. And this one's actually deep to the flexor pollicis longus tendon. When we turn long axis, there's the tendon. There it is deep to that in between the tendon and the bone. When we add color, it's got vascularity. Again, with MV flow, it's glowing. So it's very vascular. And with this one, I'll point out that notice that it's deep to the tendon. It's not superficial, which helps you differentiate this from this next abnormality that I'm going to show you. So this is a patient also at the ventral thumb, the base of the thumb, presenting with a palpable mass. And you can see there's this hypoechoic, solid appearing mass. This one has somewhat ill-defined irregular margins, but also has vascularity. So you might be wondering, is this another giant cell tumor? But look at how it's very almost like nodular and cord-like, extending out irregular margins, but it is abutting this flexor tendon. This turned out at surgery to be fibromatosis, and this is often in the differential for giant cell tumor. And this type of palmar fibromatosis, this is the most common superficial fibromatosis. It can also occur on the plantar surface of the foot, but less commonly. We see this more commonly in older males with diabetes, and it will appear hypoechoic and hypervascular like a giant cell tumor, but it's superficial. It starts in the subcutaneous tissues and then grows down towards the flexor tendons, where it can progress to a deputrin contracture, where you get these nodular cord-like masses that will adhere to the tendon sheath and cause that characteristic flexion contracture, which we don't tend to see with giant cell tumor. But again, often you need pathology to differentiate the two. And the MRI appearance is pretty variable depending on the degree of cellularity. This patient did go on to have an MRI for surgical planning. We can see it's this ill-defined enhancing area, but notice how tightly associated it is with the flexor pollicis longus tendon there. All right, so now I'll finish up by talking about the post-operative thumb. So this patient had a history of left thumb laceration with a skill saw. And do you see any injury there? So you can see there's a first metacarpal fracture and a trapezium fracture. You can see the fragmented bone here. And then also you can see the soft tissue lacerations here in the area where the saw went through. So if you recall, the APL will insert here at the base of the first metacarpal, the EPB inserts at the base of the the proximal phalanx, and then the EPL inserts at the distal phalanx. So unfortunately, the patient actually transected all three with this injury. They did go on to tendon repair, but then represented to the surgeon with limited extension of the thumb. So there was a question of, is this just due to adhesions and scarring, or has this reconstructed tendon ruptured? So they were sent to ultrasound. So is ultrasound good for postoperative tendon? Yes, it's quite accurate because we can evaluate not just for re-tear, but also any infratendinous foreign bodies. Is there any abnormal tendon motion with dynamic evaluation? And is there tendon callus or scar formation? And there's advantages there over MRI because usually after surgery with all the suture material and surgical clips, there's a lot of susceptibility artifact, meaning that there will be this black cloud of blooming on MRI that will distort the images. We also can't do dynamic imaging with MRI, and MRI is more expensive. All right, so with this patient, we're going to start by putting the transducer right over this area, and this was a few months after the repair. So you can see here, so there we're looking at the EPL, which was reconstructed. It's a little hypoechoic and thick, but notice how there's this bony excrescence here pushing against the underside of it. That represents the fracture site here that healed kind of exophytically. And so that could be a problem that it's touching the bottom of the EPL. But as you'll see, the patient has bigger problems here. So for this next image, we're going to put the transducer right down here at the carpometacarpal joint and long axis, so a bit more proximal. So here we can see there's a little joint effusion there, which is not unexpected at that CMC joint. There's the EPL tendon, but then what's this? We've got this anechoic cleft here, complete defect, indicating that there was a re-tear of the extensor pollicis longus tendon, and the proximal tendon was retracted off the screen. So now what we want to do is evaluate the remaining tendon here. So if we flex the thumb, if there's no other tear, then we should see this tendon retracting, right? Well, this is here we're flexing the distal phalanx at the IP joint. We're in the same area here. And what do you notice here? Is this tendon moving at all? This is the site of the proximal tear right here. But this tendon stem should be moving. So that the fact that it's not tells us there's a more distal tear downstream. So let's look downstream. So now we're at the distal phalanx. There's the IP joint and the proximal phalanx. Here's that thickened postoperative EPL tendon. And notice that there's this tendon gap here that's filled with this echogenic fat and hemorrhage, telling us there's a tear. There's also a little anechoic fluid defect there, that this is all part of the tear here. And then you can see the EPL tendon assumes a normal caliber, and off screen did insert normally onto the distal phalanx. So not only did they have a proximal tear, but they did have the second tear, two tears of that reconstructed tendon. So what does the surgeon want to know when we're evaluating these complex cases? So if there is a tear, they want to know, where is it? And also, is it full thickness, like in this case, like complete, or is it just a partial thickness tear? And when it's complete, the extent of tendon retraction is helpful for them to know. Also, did the tendon pull off any bone? was there an avulsion injury, which we can usually see quite well with ultrasound. And with these cases, I strongly recommend you read the op note. It will save you a lot of pain and frustration rather than just trying to sort this out with no history. All right, so the last thing I'll talk about is thumb opposition. So the thumb is special because it's the only digit in the hand that can oppose or pinch itself to the fingers. And there's three muscles that are responsible for that opposition. And here's that same diagram that I showed you before of the thenar eminence. We're at the ventral side. So there's the abductor pollicis brevis, the flexor pollicis brevis, and the opponens pollicis. So these are all the big muscles of thumb opposition. Now, the nerve supply for these muscles is unique. So the superficial muscles are innervated by the median nerve. So the APB, the OP, and the superficial head of that flexor pollicis brevis. So all these superficial muscles. Whereas the deeper thenar muscles are innervated by the ulnar nerve. So that's relevant when you have a history of a patient with a nerve injury. So this patient actually presented, they had a history of median nerve transection. So their median nerve was split from a laceration, and they developed a nerve palsy and lost the ability to oppose their thumb. So do you see any abnormality here in the orange distribution of the superficial thenar muscles, which represents the median nerve distribution? And I'll give you back that comparison normal as a guide because it is a little tricky. We can see that the APB and the OP muscles, those are kind of echogenic and diminutive in size, suggesting that there's denervation, edema, and atrophy there. And those are part of the muscles of opposition. I think the flexor pollicis brevis superficial head is not involved here, either because the median nerve was not totally lacerated, or sometimes this muscle can have a variant ulnar nerve supply. So do you notice anything else odd about this side that we don't see on the normal thenar eminence? Like, what's that? There's like an extra tendon here. Well, this patient had had an opponensplasty surgery. So let me finish up by talking about opponensplasty. So this is a unique surgery that's used when the median nerve injury or muscular trauma causes loss of the ability for the patient to oppose the thumb. And so what the surgeon will do is correct this loss, often by taking a tendon from a different part, a finger or somewhere else, and reinserting it to kind of replace that injured tendon. So the most common, and the one that the patient I'm about to show you had, is using that flexor digitorum superficialis tendon of the ring finger. So here's the ring finger. And what the surgeon did is take one of the slips of this tendon, they made an incision here and took the tendon out. And then they brought it down and kind of looped it through a little connective tissue loop they made from the flexor carpi ulnaris tendon here at the pisiform bone, and then slung it through that, and then attached it to the base of that proximal phalanx where that APB muscle inserts. So you can see how this can act like a pulley and kind of reproduce the opposition movement. And there are some other tendons that have been used, but don't worry about that. You can always look it up if you encounter that patient. So let me just kind of walk you through this. We're going to start in short axis. We have the transducer right here, and I'm going to scan on this cine from this in this direction. So here on the ulnar side here, this is actually the flexor carpi ulnaris muscle and tendon there. And you'll notice the opponensplasty coming right up against it. This is the opponensplasty there. So we're kind of right at this area. That's where it's looped in. And now it's going to dive over radially over this direction. So just to show you that again, there's the opponensplasty coming down. There it is looped against the flexor carpi ulnaris, and then it's extending over. So it's kind of moving over there. So that's step one. We've shown that that's intact. So that's great. So now if we're imaging in this area, we want to see, is the tendon intact? We need to do some kind of dynamic evaluation. So this is that we're scanning the tendon right here now, and I'm having the patient oppose as we're scanning. So is it intact? Yes, this is great news because it tells us that at the very least, there's no full thickness tear because we're seeing that the tendon is moving with opposition. There's a little fluid around the tendon indicating some tenosynovitis, but the tendon is intact, which is good news. So then next, this cine will kind of show you we're scanning along this direction close to the insertion. So we're kind of in short axis. So that's the opponensplasty tendon. It looks intact. We don't see any defects. We're getting close to the thenar eminence, which is great. there it is. Now we're at the thenar eminence. This was that static image I showed you before with the APB, the opponent's pollicis, and there's the flexor pollicis brevis. We're getting a glimpse of that flexor pollicis longus tendon. And now we'll continue to follow this as we're getting close to the insertion site. And then this final cine, so we're right here in short axis. I'm going to scan right up until the insertion. So here the tendon looks good. We continue to follow it, looks good. Uh-oh, what's that? There's this hypoechoic or anechoic cleft there. And that tells us that there's a partial thickness tear of the opponent's plasty tendon at the insertion. And then here it is. I think it's much more convincing in real time, but these are the static images. There's that short axis image showing the partial thickness tear. Long axis, there's the opponent's plasty tendon coming in, inserting on there. There's that anechoic cleft. So this is very useful information for the surgeon. It's a partial thickness, not a full thickness. They decided to do conservative therapy as opposed to going in again and revising the tendon. But again, like the last case, you really want to read the op note. Otherwise, you will really suffer going through these cases if you are not sure what exactly the surgeon did. All right, that was a lot of thumb information. I hope you have a thumbtastic time. And I included some references there if you'd like to do any further reading on the thumb. And I'm also happy to answer any questions that you might have. Thanks for your attention. Let's see. I'm checking the webinar chat. If you have any more comments, you can include those. You're welcome. I'm glad the post-operative information was helpful. That's one of the, I think one of the great advantages of using ultrasound for post-op evaluation. You're welcome. Glad you found it helpful. All right. I think that's all the questions.
Yes.
Okay.
Hi, Dr. Kowal.
Hi.
No, that was a great presentation. And for attendees, as a reminder, if you do have questions, go ahead and submit them into the Q&A box.
Oh yeah, someone mentioned that they do not have a hockey stick probe, but they have a linear probe. You can actually get away with with a larger footprint linear probe with the thumb. The hockey stick is really helpful for getting that small footprint, but especially if you use a lot of gel, an 18 or even a 14, you can see a tremendous amount of detail, including the pulleys and some of the finer elements. So while a hockey stick is very helpful, it's not essential. Someone asked if they could use a 12 megahertz transducer. That would be a bit of a challenge. You could definitely use it for like tendon evaluation. It would be harder to see some of the pulleys and the retinacula, but you could get it done. Someone's asking if they can get a copy. This will be on the AIUM website for I think 3 years. Is that right, Ashley?
I'm so sorry, say that again?
A recording. This recording will be on the website for like 3 years, right? Someone was
Yes.
okay.
Yes. I'm sorry, I didn't see that one come through, but yes, webinars that are recorded are on our online learning center, and they are available for 3 years. I'm going to go ahead and take the screen back over, Dr. Koval. That was a great presentation and wonderful comments. So thank you. And AIUM would also like to thank Samsung for partnering with us to make this webinar possible. As a reminder, you will receive an email within 24 to 48 hours with a link to review the recording. And lastly, when leaving the webinar, you will be prompted to complete a brief survey. We would appreciate any feedback you could provide. We will use that to help us plan our future educational offerings. With that being said, we'll close out this webinar. Thanks again for joining us and have a great rest of your day.